Good afternoon. Is Meghna there?
Yes, ma'am.
Has Dr. Vishwas joined?
Yes, ma'am.
I'm here, Dr. Singh.
Okay. Good afternoon. This is.
Hi, how are you?
I am fine. This is afternoon at India, so I do not know how to calculate the time out there. So, is it a morning hours?
Yeah, it's 6:30 in the morning here.
Okay, so fairly early. Good to see you
Yeah.
awake and ready with this academic endeavor. So, before delaying any further, I think we have quite a number of people already joined, because generally the attendance in such classes is around 25, maybe 28, something like that.
Okay.
And has Sujoy been able to join? Dr. Sujoy?
I think I heard him earlier.
He was having some technical issues and, he told me carry on. So I think we should be keeping up with the time, seeing that it is morning hours and you have to also go for your work. So good afternoon, everyone. This is the next of the topics in the series that we have clubbed under trainings beyond boundaries. And everybody knows that here we dissipate the knowledge one-to-one basis, and one is so open to ask the questions and clarify the queries. And this is the main basic aim of this program. Otherwise, in didactic lectures, generally the people come, they dole out knowledge, people listen, half received, half gone, something like that. And so even they again come out of the lectures with lots of doubts. Here, I would again encourage my students, the other residents and other people. Even you will be pleased to know that many of our staff nurses have also got enrolled in this program, our junior resident, because this is one of the very important topic, basics of basic concepts of neonatal and pediatric ventilation. You will be pleased to know that our department is going further and is going to have its own neonatal surgical ICU and pediatric ICU, pediatric surgical ICU, which will be separate from the central pediatric ICU. So while we are endeavoring this and already the ventilators on the way to purchase, then it is very important that people should know how to operate on them. And I'm very sure you will be touching upon the basics so that the operators, they will know why they are doing what they are doing. So before going any further, let me ask Dr. Meghna to introduce. It is such a good luck for all this listening team that we have such a coveted person who will be telling us, teaching the group about these finer aspects. So Dr. Meghna, I kindly introduce Dr. Vishwas.
Yes, ma'am. Good morning, sir, and good evening, everybody in India. So it's my pleasure, and it's our pleasure that Dr. Vishwas Seshachellam sir is with us and will be speaking on the topic about pediatric ventilation. Sir was born and raised in Sacramento, California. Sir finished undergraduate education at the University of California at Davis, and then went on to complete medical school at Midwestern University in Glendale, Arizona. He finished his anesthesiology resident at University of Texas, Houston, and then subsequently went to Children's Hospital of Los Angeles for pediatric anesthesiology fellowship. Sir has been a faculty member at University of Texas, Houston since September 2020. Over to you, sir.
Thank you, Meghna, and thank you, Dr. Simi and Dr. Sujoy for inviting me to talk about this topic. Pediatric and neonatal ventilation was something in residency and throughout fellowship that was a little difficult for me to understand. And the only thing that makes it any better is practice. So I really hope that I can dive into some basics here. Hopefully we take a couple pointers away that can really help in your clinical wards, because it sounds like everybody's just getting busier and busier. Please let me know if you can't hear me properly or if anything needs to change during this presentation. I'm more than happy to keep this very informal, so please feel free to ask any questions during the presentation, and I'm happy to clarify. So
I will request all the participants that they should be ready to ask questions and clarify their doubts. It is a great endeavor and I think efforts of Dr. Sujoy that
can everybody hear me still?
Yes, we can hear your lovely voice.
I don't think it's allowing me to share my screen.
Meghna, you can do it. I'll try from my just done. You may try now.
Yeah, perfect. Give me 1 second, sorry.
till the time you are trying. Dr. Sujoy, how many ventilators we have now for going to have for our nursery as well as for pediatric?
Baby log, I don't know whether Vishwas has that range. Baby log from Drager is already supplied in our hospital, my store. It's going to be installed by this month end. And 4 for the Drager universal ventilator from neonatal to pediatric age group for 12 years. It's going to be delivered in another 1.5 months. So we'll start with neonatal ventilation.
Sorry, give me 1 second.
No problem, Vishwas. Take your time.
I may have to rejoin this lecture. There's some setting that was turned off. I'll be right back, sorry.
No issues, take your time.
Do we have nursing staff people also there? They have not joined. Priyakant and all that. All those.
Yes, ma'am. I'm there.
Now you are there. Good. Anupa and all those people.
No,
are
ma'am.
not
I
there.
talked to a lot of people are having duty and a lot of busy schedules. I talked to Sister Shirley and she's saying कि आप ले लो और बाद में you can explain. ठीक है मुझे.
Okay, they could have at least joined. They can later on share the YouTube.
Okay, ma'am.
At least they can join and
yeah.
even if they are not available, but at least and later on they can go through the YouTube. Maybe that will show that they are interested in.
Okay, let me call ma'am. मैं call करता हूँ.
Okay, can everybody hear me still?
Yes, we can see the screen and hear you as well.
Okay. Sorry about that. So I think there's a setting on my computer not allowing me to start. Okay. So this is an introduction to pediatric and neonatal ventilation. This is our medical center in Houston here. You can see many hospitals. Let me just turn my pointer on. So our hospital is this one here in the corner, Memorial Hermann Children's Hospital. Just wanted to give you a background here where we work. So Children's Memorial Hermann Hospital is in Houston, Texas. Currently, we have a 30-bed pediatric ICU, 90-bed level 4 NICU. We have about 20 pediatric anesthetizing locations, including 10 operating rooms, several outside locations. So lots of anesthetizing locations on a day-to-day basis. We're very busy every day. You can imagine with the 30-bed pediatric ICU, 90-bed level 4 NICU, we're the largest trauma center in the nation. So we see everything from very sick little premature neonates all the way up to adolescents who have very complex pathology and necessitate our services. A little background that I wanted to give you before starting this lecture is I am trained in pediatric anesthesiology, and a lot of the ways that we go about ventilation is very different from how others undergo ventilation in the pediatric ICU. So just take everything with that in mind that I talk about today. with the fact that my background, and I'm by no means an expert in ventilation, but it is something that we do on a day-to-day basis. So everything that I say will be how we operate in the operating room and things that we think about from an anesthesiology and anesthesia standpoint. So our objectives today are to review the basic concepts of pulmonary physiology that relate to ventilation, discuss the indications for ventilation. For every procedure, as you know, we should always know indications, contraindications. Describe the vocabulary of ventilation. That'll help us describe ventilation settings, ventilation modes, why we choose certain ventilation settings and modes, which will become more clear throughout the presentation. Discuss the problems that can occur with ventilation. Again, ventilation is a procedure that we undergo every day. And with any procedure, there are risks and benefits. And then we'll go into some neonatal ventilation strategies and briefly touch on neonatal ventilation and how it pertains to pediatric ventilation and how it differs from pediatric and conventional ventilation. So starting off with any disease process, we always have to start with the development of how pathology comes to exist. With regard to respiratory development, development begins at several weeks after conception and goes throughout the first decade of postnatal life. So around 26 to 28 weeks of life, it's a very important stage. Capillary networks begin to form around terminal air sacs, and these proliferate and eventually form alveoli around 36 weeks. So viable age for a fetus or an infant is around 24 weeks, and this is the reason why. At birth, the neonatal lung contains around 10 to 20 million terminal air sacs that are participating in gas exchange, and this is only about 1/10 the number in the mature adult lung. And the point here is that lung development doesn't stop at birth. Much like many of the other organs, the kidneys, liver, lung development actually goes up until the patient is 10 years old, so keeps going after birth. With regard to the mechanics of respiratory physiology, inspiration, as we know, is an active process. This means that tidal volume is determined by diaphragm contraction and muscle contraction in general. It requires energy, requires oxygen consumption, ATP. And then if the diaphragm contracts and an adequate vital capacity or tidal volume is not generated, then other muscles can help add some negative pressure for ventilation as well. This includes intercostal, abdominal, sternocleidomastoid, and neck muscles. Expiration, however, is a passive process. Once the diaphragm contracts, the diaphragm can relax and passively push air out of the lungs, out of the oropharynx and nose into the environment. However, this changes during respiratory distress or any other times of vigorous breathing, asthma, airway obstruction, a lot of indications for intubation and ventilation. So both disease processes are active, and we were talking about how inspiration requires oxygen consumption and ATP. When respiratory distress or times of vigorous breathing come into play, both inspiration and expiration become active, consuming oxygen. And the faster we consume oxygen but don't ventilate to provide oxygen, the faster we have respiratory distress. And this is when patients are very critical. So chest wall compliance is very important to discuss when talking about adults and infants and children. There's a key difference here that I wanted to point out. And again, this respiratory physiology portion of the lecture is not exhaustive. There's a lot of information on respiratory physiology, which we, for the sake of time, can't touch upon here, each of which can be an hour-long lecture. But what I wanted to touch on here is just what the differences are between adults and infants and children, because they'll pertain to our ventilation strategies and modes of ventilation that we choose later on, and how quickly we have to make changes for infants and children. So the point here is, if you look at this image, adults have adequate chest recoil due to a rigid chest wall. We're able to maintain small airway patency because this chest recoil counteracts the lung recoil that is intrinsic to the lung. So in adults, we're able to maintain our alveoli open, and provide oxygenation that way and have what we call an adequate reserve. However, in infants and children, this chest wall, as you know, is very pliable. This will collapse with almost no force. And what happens is at the end of expiration, the lung will recoil. However, this chest will follow with it because of the decreased muscle wall rigidity and the decreased compliance. Increased compliance. This can lead to atelectasis, small airways collapsing, alveoli collapsing, and what happens here is the reserve is far decreased, which leads to rapid oxygen desaturation in times of apnea. Any questions about this?
None so far.
Okay. With regard to lung volume, so this is something that you'll see used when obtaining pulmonary function tests for patients. A lot of these names and nomenclature is not relevant to our talk today. There are three that I wanted to talk about because we'll be using these terms throughout this lecture today. So as our tidal volume, you can see here, the amount of air inhaled during one cycle of respiration. So just maintaining shallow respiration. All of us are just maintaining our tidal volume now. Vital capacity is the amount of air exhaled after maximal exhalation. So the way I think about this is you exhale, take a deep breath in, and that's your vital capacity. Functional residual capacity is the amount of air that remains in the lungs following a normal expiration. So you see that here. After one tidal volume expiration, the amount of air that remains in the lung is your functional residual capacity. This is very important for us today because it is the main component that leads to time of desaturation in neonates, infants, adults. If patients have a higher functional residual capacity and are able to oxygenate and ventilate this area adequately, their time to desaturation will be a lot longer than, say, a neonate, like we discussed in the previous image, that has a pliable chest wall. Everything collapses. This functional residual capacity is far decreased, and there's almost seconds to, or just seconds until rapid desaturation. And the key point here that I want to hit home is when an infant or a child begins to desaturate due to a decreased functional residual capacity, the time you have to act is a lot faster. So now that we've touched on a few basic physiology components, we can start talking about mechanical ventilation. So here are a couple indications for mechanical ventilation. I've hit on a few here, but there's many more indications. So number one for me and my job is necessity of controlled or supported ventilation during anesthesia. As we know, respiratory failure secondary to hypoxia or hypercarbia is also an indication. Any neuromuscular weakness, for example, Guillain-Barré syndrome, or neuromuscular blockade, diminished respiratory drive with regard to CO2 narcosis or any trauma, to decrease a patient's work of breathing. If a patient is septic, if a patient for any reason has an increased work of breathing that you would like to control, mechanical ventilation is indicated. And any neurological impairment, trauma, intracranial processes. We see a lot of intracranial processes in our hospital that come to the operating room and need intubation and ventilation to support their life. And there's many more indications that I haven't touched on here. So a couple definitions. This is a lot of vocabulary and definitions.
Dr. Vishwas,
yes.
I think since our residents will be totally new to this concept, if it could be told to them that what defines as respiratory failure for neonates when they have to be, taken as that he is requiring the ventilation,
sure.
That may be clarified in details, please, both for neonates as well as for children.
So respiratory failure, if they're hypoxic on any supplemental oxygenation and you've attempted mask ventilation, nasal continuous positive airway pressure, and they're still desaturating, if you're obtaining an arterial blood gas and their oxygenation is not adequate at all, and the key concept here is in children and in neonates, when they have impending respiratory failure and oxygen desaturation, the time to act is very, very minimal. So what I would say the take-home point here is if you're concerned about a patient who has an increased work of breathing, if they're using their accessory muscles, if they are asthmatic, if their PCO2 is 70s, 80s and climbing, and you're trending the PCO2s or the PO2s keep dropping despite any non-invasive efforts, this is an indication for intubation and mechanical ventilation before the patient is in extremis and requires intubation urgently. Did that help clarify a little bit?
Is there any particular criteria on the blood gases or respiratory rate, as they said that more than 40?
Yeah, so for
that may be
for neonates, I would say respiratory rate, if they're breathing above 50 to 60, that may be pretty concerning. For adolescents, I would say if they're breathing at a rate of 30 to 40, it really depends on the whole clinical picture, because you have to rule out whatever else could be going on underlying. So in our operating room, if we're anesthetizing a patient, if it's a teenager or even an 9-10-year-old who's breathing at a rate of 40, this could be secondary to stimulation pain. So we treat that prior to intubating the patient. So if their respiratory rate is elevated, and if they're just participating in what we call dead space ventilation, they're really splinting, not able to take deep breaths, not able to maintain their oxygenation and ventilation, then that may be an indication for ventilation or mechanical ventilation.
So if I summarize correctly, for all of my residents, I think we can summarize like this, that any patient, even with the maximum non-invasive oxygenation we have, still saturation of oxygen is dropping. Work of breathing is visible. That means accessory muscles are working. Then you have tachypnea. You have something of starting of a bradycardia. And then ABG, you have low PO2 and you have rising PCO2. This is despite the non-invasive oxygenation which you are giving. That I think summarizes everything. That's what impending failure is.
Exactly. Thank you. Thank you for helping summarize. Thank you. So some definitions that we have to talk about before talking about ventilation and the modes of ventilation. There's 3 key definitions I want to talk about here. And the main 2 are these top 2: peak inspiratory pressure, positive end expiratory pressure. These are terms that we use every day in the operating room on every patient on a ventilator. So peak inspiratory pressure is denoted here on this diagram. It's the highest level of inspiratory pressure that's applied to the lungs during inspiration. So expiration is here. Inspiration, this is the peak inspiratory pressure at the top. Usually it's measured in centimeters of water. In addition, positive end expiratory pressure is another very important topic or vocabulary word. So positive end expiratory pressure, also known as PEEP, is the pressure in the lungs that exists after maximal expiration. So after an inspiration, this is expiration coming down here. This is PEEP, the pressure in the airway after expiration. And we'll explain why these are important. The plateau pressure is a value that's measured on the ventilator, oftentimes in the ICU. And it's the pressure applied to small airways and alveoli during the inspiratory pause. So on a ventilator, you would see an inspiratory pause on the ventilator, and this is how you measure the plateau pressure and the small airway and alveoli pressure. Expiration, and you can measure your PEEP or with the PEEP that's applied.
Excellent diagram, excellent figure. Just interrupting Vishwas.
Sure,
I just wanted to bring to the notice of everyone participating that we also have Supriya who has joined. Supriya is the application manager for Dragon. So it is her device which is going to be installed. So I had requested her to be a part of this meeting so that she can know where to train and how much we already know because of this talk of yours. So
Perfect.
Please carry on. I think one of the best figures you have shown.
Definitely. Thank you. So positive end expiratory pressure, also known as PEEP. I put an exclamation here just to denote how important PEEP is. So it's important for lung protective ventilation. And what lung protection refers to is a lower tidal volume and the use of PEEP. So traditional ventilation before involved using higher tidal volumes and minimal to no PEEP. And naturally, people are ventilating patients with higher tidal volumes thinking, okay, if I expand the lung, I'm providing ventilation, I'm protecting the patient, oxygenating well. However, we've shown that patients with using lung protective ventilation actually had improved outcomes. And patients with acute lung injury actually improved and had decreased mortality. So without PEEP, what happens is you have atelectasis. So think again back to, we were talking about neonates and infants and their highly pliable chest wall that collapses the lungs. If you apply PEEP here, if you provide this pressure on the ventilator, you can maintain small airway patency. So without PEEP, small airways and alveoli collapse, and you have resultant hypoxemia because that's less alveoli that you're oxygenating and less alveoli that have oxygen in them. Physiologic PEEP for us, even standing here, me talking, about 3 to 5 centimeters of water. So at minimum, I always tell all of my residents and fellows, always have a PEEP of 3 to 5, at least 5 on board for any patient. And this may change from patient to patient depending on their pulmonary history and their pulmonary pathology, if any. Questions about this? So what is a ventilator? It's any machine that provides mechanical ventilation. So my question to you is, does this have to be electronic? Does it have to have an electricity source? Does not. So this is the simplest ventilator and a lifesaver. This is bag mask ventilation, hand ventilation. So before I go any further, every patient that has impending respiratory failure or is on the ventilator should have an ambu bag at bedside. This is because this is the emergency use device in case there's an electricity failure, if the ventilator does not function appropriately, and if you just need to take over, hand ventilate the patient and provide some recruitment maneuvers and hand ventilation in order to ventilate this patient. So with hand ventilation, you can ventilate through a face mask, laryngeal mask airway, endotracheal tube, or a tracheostomy tube. The components of bag mask ventilation or hand ventilation include fresh gas flow. So fresh gas flow in this instance would be oxygen supply through this tubing here, a reservoir bag, which is on the end here, a breathing system, and this is the bag which can be compressed. And an additional addition here is a PEEP valve that you can add. So in effect, this whole thing is a ventilator. It's just hand operated. So why not use these all the time? They're cumbersome, can lead to fatigue, they're imprecise, and a single provider cannot perform other tasks, and this will happen. So because of this, we started to use ventilators. So older anesthesia ventilators looked like this. I've seen maybe 1 or 2 in my life. The cons to using this type of ventilator is a tidal volume that's desired will not always be delivered. So you can think about your small neonates, small infants that have to undergo ventilation. If a set tidal volume was delivered here, the circuit compliance, respiratory rate, fresh gas flow, inspiratory time, several other factors, the bellows, the compliance of the ambu bag, they all factor into how much volume is actually being delivered to a patient. So if you need to deliver a tidal volume of 12 and you dial this in, this tidal volume may change to 20, 25. You don't really know what tidal volume is being delivered when. So it's a major drawback for these ventilators. However, it was better than hand ventilation. So with our modern ventilators, there's multiple modes that are available to use. They can deliver very precise tidal volumes. They can compensate for circuit compliance and deliver tidal volumes that are not dependent or coordinated with fresh gas flow. This is a very big change. Previously, fresh gas flow would be a factor of what tidal volume is delivered, inspiratory time, Now this can all be independent and the machine will deliver exactly what you set the machine to. So multiple modes are available to use. A couple that we'll be talking about today are pressure control, pressure support, volume control, and volume control auto flow. Also called pressure regulated volume control. And we'll define these now. So these are some modern ventilators. The one in the middle is our anesthesia ventilator. I just put this here to show you what we have in the operating room. We have some older machines, but this is the newest one that we have. On the left is the Draeger Evita Infinity V500. And on the right is the Baby Log. And I think the Baby Log is what you guys are receiving. And I'm not sure in the pediatric ICU which ventilators.
Supriya, you will be able to tell us, is this the same model we are receiving?
Sir, these are just one generation older ventilators. So now you will be receiving the one which is Evita Infinity V800 and Draeger Baby Log VN600. So these are the latest ones which are just launched. So you will be receiving those.
So thank you, Supriya. Vishwas, we overtake you in terms of
Okay.
technology.
Okay, so the ventilator circuit. So this
Dr.
diagram.
Vishwas, sorry to
Yes.
interrupt you. I think our residents also need to be clarified the concept of pressure control, volume control, the
Yeah,
intricate
I'm
part
talking
and
about
why
this.
it is. Okay,
Sure.
thank you. So
Yeah.
sorry to interrupt.
No, it's okay. So this is a ventilator circuit. This is also important to know. It looks very intimidating and looks like a lot of components going on, but just wanted to point out a couple components here. So ventilator circuit, you have a fresh gas inlet here. This is where your oxygen and air can come into the circuit. You have a unidirectional inspiratory valve. This will close during expiration. So inspiration goes here, inspiratory limb. You have a Y piece connecting to the patient here. Expiration begins with expiratory limb. There's an expiratory unidirectional valve here, which will close during inspiration. And the CO2 canister here that can absorb CO2. Your ventilator is here. An APL valve, which on our anesthesia machine, this is more specific for an anesthesia machine. But the point of the APL valve is you can close the APL valve to provide PEEP while hand ventilating here. This may be beyond the scope of this talk because it'll be a little different on the Draeger machines. But the importance here is when you're using hand ventilation and you have a PEEP valve attached. So if I go back to this image here, if you have a PEEP valve attached here and you close this PEEP valve and you ventilate here, this bag is equivalent to this bag here. So you squeeze this bag, air will go through, follow through the inspiratory limb. And when you release the bag, air will come out through the expiratory limb and out this APL valve that's open. So just a little bit about the ventilation circuit and dead space. So what is dead space? Dead space is a volume of ventilated air that does not contribute to gas exchange. And why this is important is any portion that is distal to the Y piece. So remember on this diagram, this Y piece here, any portion further than this, in between this and the patient, contributes to dead space. So any volume of ventilated air that does not contribute to gas exchange, any portion that's distal to the Y piece and dead space and effectively ineffective ventilation to the patient. So I want to show you why this is significant. So this is just a picture of dead space ventilation. Here's the Y piece here. This portion here is equivalent to this portion here, and you can see it here. So this portion, serving it as extension, participates in dead space ventilation. Now this patient looks a lot older than any patient that we take care of, but if you can imagine a neonate who's coming in for a craniotomy in our instance, if somebody puts extensions on here, they may think that, okay, we're adding extensions just for the ease of ventilating this patient. We need to connect this patient a little bit. The circuit wasn't reaching the patient, or just for mechanics in the NICU, PICU to provide that extension. these extensions are not without consequence. And this will make sense on the next slide. Each addition to any piece distal to the Y piece adds dead space. So this one adds 25 milliliters of volume of dead space. If you're ventilating a 2 kilo infant and you're going for a goal tidal volume of 6 to 8 milliliters per kilo, your goal ventilation is 16 milliliters per tidal volume. If you set your machine to 16 milliliters and have a 25 milliliter connector as dead space, you can imagine how your ventilation will be. Questions about dead space ventilation? This is mainly for the setup of your NICU ventilators and PICU ventilators and ensuring that the ventilator is set up correctly before connecting them to the circuit. So now going into ventilation modes. So we talked about the different types of ventilation: volume controlled, pressure support. Now we're going to go into the details of each ventilation mode. And feel free to chime in, anybody, if you have anything to add for these modes, especially Draeger representative probably knows the machines much better than I do. So for volume controlled ventilation, the definition, it's a time cycled, but it's volume limited. So what this means is you can set a certain tidal volume on the machine, dial in that tidal volume, and this leads to variable pressure based on the tidal volume delivered. So you dial in a tidal volume and the machine will measure the pressure that you're achieving with that given tidal volume. However, a tidal volume will be delivered. Pressure controlled ventilation is also time cycled, but pressure limited. So this, you set a pressure on the ventilator mode, on the ventilator, and the amount of volume that is produced is based on the pressure. And this will become very evident in the next couple slides. So for volume controlled ventilation, when you set a volume on the ventilator, you have constant flow throughout inspiration. So you can see that here. The peak pressure is reached at the end of the ventilatory cycle. And remember, this is the peak inspiratory pressure that we were talking about on the previous, on that one diagram early on. We were talking about peak, PEEP and PIP, peak inspiratory pressure. So you have constant flow throughout the respiratory cycle, peak pressure achieved at the end, and a tidal volume delivered. The pressure here is what will be measured. This is volume control ventilation. You can remember this by you are setting the volume. So this is in contrast to pressure controlled ventilation. So in pressure controlled ventilation on the anesthesia machine or the ventilator, the flow is increased at the beginning of the respiratory cycle and gradually declines. Pressure is maintained through the inspiratory phase. So you can see how this flow is maintained in volume controlled ventilation and pressure is maintained during pressure controlled ventilation. So the machine will deliver peak flow, hold the pressure, and the tidal volume, because you're holding the pressure, the volume will gradually increase. You can imagine constant pressure, you're opening the proximal alveoli, opening the distal alveoli, opening up more and more alveoli as you ventilate, increasing the volume, and then expiration. Questions about these two? And I can send these slides so you can review if you'd like as well.
So I wanted to ask that, is there any indication for volume-based ventilation in neonates? Can you think of anything in which we have to go for volume?
The only time I can think of using volume, we use volume-based ventilation in the operating room very frequently. However, because neonates have highly different respiratory mechanics, they are at risk for barotrauma more so than adolescents. If it were me, I would start with pressure controlled ventilation for neonates and slowly titrate, solely because you can titrate the pressure. You know exactly which pressure you are setting to achieve a certain tidal volume. And that way you don't risk barotrauma. The scary thing about what Dr. Suju I think is pointing to is if you set a volume on a ventilator in a neonate to say,
yeah, exactly I asked, exactly the reason I asked, because I believe the traditional teaching here is that you should stick to pressure ventilation, because you can have barotrauma.
100%. And the scary thing, this has happened in the operating room before. Someone everyone means well, obviously, to help out with the patient, but someone goes and sets the ventilator to 50 cc's for a 5-kilo child. That's 10 cc's per kilo. If you do this, your peak, and then all of a sudden you look at your anesthesia ventilator and it's alarming with a peak inspiratory pressure of say 40, you're at risk for barotrauma right then and there. Children, especially if they have bronchopulmonary dysplasia, which is something that we'll touch on later, if they have bronchopulmonary dysplasia, their airway resistance is already high, and you're introducing them to these high airway pressures, your risk for barotrauma is very high.
So volume controlled one is generally reserved for in a few settings only.
So volume controlled ventilation, you can use early on, but we can use these for adolescents, children, in general in our operating rooms, because we're very vigilant about what settings we use, and we actually preset values in our ventilator before connecting any child. You can use volume controlled ventilation. I think the risk here is if you're not vigilant about monitoring your peak inspiratory pressure, there's a lot more mistakes that can happen with volume controlled ventilation on neonates. That being said, sometimes we go between volume controlled ventilation and pressure controlled ventilation. And for whatever reason, some patients just tolerate volume controlled ventilation a little bit more, whether it's because of the constant flow, the peak inspiratory pressure at the end, and the nature of which volume is delivered to these patients. Sometimes volume controlled ventilation is tolerated a little bit better.
As a take-home message, Vishwas, as a take-home message for my kind of residents who are just going to try out, if I say that strictly pressure controlled, no volume controlled ventilation, would that be wrong?
It wouldn't be wrong. It wouldn't be wrong. Mainly because you can titrate the pressure slowly higher and higher to achieve the same type of ventilation.
Because we have to get and increase our staff and the supporting staff, because we are not going to achieve the full rate of being vigilant for a newborn initial launch. So, and plus they will have they also probably many of them just joined, so they don't even know how to diagnose a pneumothorax. So if I can tell them no volume control, go for pressure control and achieve tidal volume through pressure.
Sure, for neonates especially, yes. But so there's another mode of ventilation that should be available on your machines that I'm talking about next, which actually is the best of both worlds if you can use this one. So pressure regulated volume controlled ventilation kind of combines the first two. To start, this may be a little complicated, but it's basically a combination of volume controlled ventilation and pressure controlled ventilation. So it's a combination of the decelerating flow pattern. So in pressure controlled ventilation here, decelerating flow pattern, along with the guaranteed volume delivered. So basically what the ventilator does is after connecting the patient and administering the first breath, the ventilator learns what the patient is doing and determines the plateau pressure. With this plateau pressure, the machine will automatically adjust the peak inspiratory pressure to deliver a guaranteed breath for each subsequent breath. So it's basically volume controlled ventilation, but with the safety of pressure control ventilation. So this is something that we use in the operating room a lot because we have first-year residents, second-year residents coming through their pediatric anesthesia rotation. And it's actually what I think is the safest because you're still using basically volume and pressure control. You're limiting the volume by setting a target volume. We're also limiting the pressure that you're administering. So this mode of ventilation may be actually the safest for the residents to use in the NICU and the pediatric ICU.
Supriya, we have this, right?
Yes, sir. By the name of autoflow, this mode is
volume
there.
Control autoflow.
Yes. And secondly, just to add, even with the baby logs, so if at all you're using the pressure control ventilation, then you get the volume guarantee. So likewise, there also using pressure control also, you can have a guaranteed tidal volume delivery. Yep. So volume guarantees, they're available in the baby logs, and with Evitas, you will be getting the autoflow.
Wow, that's great.
Yes.
Yeah. Sorry, I just want to make sure. Okay. Okay, so this is a video that I've included. I don't know if you'll be able to hear, but I just have a demonstration on the anesthesia ventilator. It's about a 3 to 4 minute video. Just wanted to show you both modes of ventilation.
You can allow the sound sharing also at your end. There is an option of sharing sound. Then the sound will also come.
Share
So,
computer sound.
Yeah. So if you do that, we can all hear your sound also, computer sound.
Okay. Okay. Can you hear?
So this machine we have here is a Draeger
We can hear it.
Perseus A500.
You can?
And I just wanted to show you a pressure control mode of ventilation versus a volume control mode of ventilation. And I have made an artificial lung here. Just using
Excuse my artificial lung.
one of our bags that's usually on the anesthesia machine. So what I'll show here is we have a flow, and just keep in mind this is artificial, so our numbers may not match up what we see clinically. But just to give you an example, so if I were to put this patient on a pressure control mode of ventilation, so remember this is titrating to maximum pressure and delivering a tidal volume based on that pressure. So click here, pressure control, and here we are set for an inspiratory pressure of 13 centimeters of water. Respiratory rate's 26, positive end expiratory pressure of 5, and this is our inspiratory time with an inspiration to expiration ratio of 1 to 1.9. So you'll notice that the peak airway pressure displayed here of roughly 13 to 14, I can alter this. So if I wanted this to be...
So this is pressure control, we're altering the pressure.
Here is 74. Now it increases, because now it is shooting for a pressure of around 20.
What is that 144, Vishwas?
Now
That's the tidal volume.
Volume control. So remember here we are titrating our tidal volumes depending on the airway pressure. If we switch to volume control, that's a different mode of ventilation where you are titrating in a set volume and calculating the pressure that it takes to achieve this. So if I go to volume control, I set my tidal
volume here. Peak inspiratory pressure is here. So now I'm setting the tidal volume. And you'll notice the volume here, you'll notice the waveform change.
Waveform here looks very different from our pressure control waveform. That's an inspiration, expiration, inspiration, expiration. So if I want to change this, I have a Pmax, the maximum pressure that's detected until an alarm sounds here. I can change this. So I can say I don't want to exceed 15. And I won't exceed that pressure of 15.
This is where I altered the pressure, the tidal volume will decrease.
So now if I deliver this, it still won't exceed that. But if I want to, and it'll say tidal volume not achieved because it's set to stop at that pressure of 15 here. Now if I want to deliver a higher tidal volume, simply increase this to 250. I have to increase this again. Now that we're delivering a higher tidal volume, and it's getting to 250. You can see that reflected here.
Okay. Hopefully that was helpful and kind of demonstrating what we were talking about. So the other mode of ventilation that is different from pressure control and volume control ventilation is pressure support ventilation. This is one that's mainly used as a weaning mode of ventilation toward extubation. So in pressure support ventilation, spontaneous breaths are assisted. So what this means is a patient controls when a breath is assisted. And you need a trigger in order to initiate ventilation. So the trigger on here, you can see by this downward deflection. And what this downward deflection is showing is the patient is taking an inspiratory effort. So when they make an inspiratory effort, the machine will recognize this and provide pressure support to assist in that ventilation. And there's a pressure support value that you set on the machine. So a certain set amount of inspiratory force is given, and then pressure support helping with ventilation. You can see downward deflection, the machine helps, and a volume is delivered. And again, this is used for as a weaning mode of ventilation toward extubation. And for mechanical ventilation, if you're totally taking over for the patient and if you want to control the patient's breathing entirely, this is not something that you would use. You would use pressure control, volume control, or volume AF, autoflow. So ventilation settings. Your ventilation goals are to provide oxygenation in order to prevent hypoxemia, prevent hypercarbia, and to prevent trauma. So that goes with volume trauma and barotrauma, and we'll talk about these in a little bit. So maintaining oxygenation, ensuring that your PaCO2 or your end-tidal CO2 does not increase too much, which you can control, and preventing any trauma. So in general, you want to choose settings to allow the following. So for volume control, just focus on this top part for now. If you're setting a patient to volume control, so again, your adolescents, your kids that are anywhere from few months to teenagers, you can use volume control safely in general. You want to set your tidal volume to 6 to 8 milliliters per kilogram, a PEEP of 5, which is physiologic PEEP at least, and then respiratory rate can be age adjusted. So for little babies, probably around 30, 35. For adolescents, anywhere to adult values, so about 12 to 16, 18. And you can alter these to maintain normal carbia. For pressure control setting, to be conservative when you're in the NICU or the pediatric ICU, set your peak inspiratory pressure to 12 to 14, and then you can titrate to goal tidal volume. So tidal volumes are equal here. So if you have a neonate that's about 3 kilos and your goal tidal volume is 18 to 24, you can set your pressure here, 12 to 14, and slowly titrate up until you reach that goal ventilation of 18 to 24 milliliters. PEEP of 5 again, and respiratory rate again will be age adjusted. And as for the FiO2 or the fractional inspiration oxygen, you want to use the minimal amount of oxygen in order to provide oxygenation, but prevent oxygen toxicity. And a lot of times what we'll do is when we drop a patient off in the neonatal ICU or in the pediatric ICU, we'll start with something pretty high, 100%, 90, 80, whatever the patient is tolerating, and slowly titrate down over time in order to safely decrease this number. So monitoring that you'll have during ventilation, you should always have a continuous pulse oximetry to monitor SpO2, an oxygen analyzer to avoid any hypoxemic fresh gas flow through the ventilator. And then sometimes you'll have, if you have an arterial line, you'll be able to draw serial arterial blood gases to check your pH, PaO2, PCO2, and titrate your ventilation that way. And end-tidal CO2 is not always available, but I think especially in neonates, it's very hard to detect. But in adolescents, if end-tidal CO2 is available, it's something that can aid in ventilation as well.
Supriya, do we have it? EtCO2. Okay,
I think it should come on all the machines. Yeah, I think it should come on all the machines. Or the ability to. I think just the tubing and the monitor itself is something you would have to ensure. So this is another video. I just took a little video of a patient that we have on the ventilator in the neonatal ICU. And again, I made the mistake of showing the machines we have because you guys do outdo us here. This patient is on a pressure control setting. And this is a neonate, so the waveform doesn't look as nice as the diagrams that we had. Let's see if we can play this again. So what I want you to pay attention to here is in this gray is patient-assisted efforts. So this is synchronized intermittent mandatory ventilation, which is very similar to a combination of pressure control along with pressure support. So every gray breath here with a downward deflection is supported with a pressure support assisted breath. In the blue is total pressure control. So I'll play this video again and you can see. So total pressure control, that's assisted. So this is a patient that's in the pediatric ICU that I took a video of. This patient is on volume control, synchronized intermittent mandatory ventilation. On here, you'll see peak inspiratory pressure, the respiratory rate, end tidal CO2 on the monitor. The tidal volume generated is shown here. Mean airway pressure, the PEEP. All of these are values that are actually being delivered to the patient and calculated by the machine. At the bottom here, you have your fractional inspiration of oxygen, tidal volume, inspiratory time, respiratory rate, PEEP, pressure support for those supported breaths, and P max, which is where the machine will stop ventilation at that pressure of 40.
So I believe SIMV now is both volume controlled and pressure controlled.
Correct.
Supriya, you had disconnected. We were asking ETCO2 is there in both the type of vents?
Yes, sir. ETC2 are there in both the Evita series. You have the Smart Care with there you can use the volumetric ETCO2 and Baby Log also. We have the ETCO2.
Supriya, I wanted to thank you that you could join so that we could easily ask you. So it makes us a very coordinated.
No, sir. It's a learning for me
Well,
also. So
No, Supriya, I must thank you and treats due because you joined so we can actually cross check with you what is happening. Thank you so much.
That's very helpful.
okay, so that's okay, sir.
So adjusting ventilation. So you have a patient on the ventilator, and how do you know how to adjust the ventilator? You can't. Sometimes you can leave the patient and they'll be fine for however long they're ventilated. A lot of times though, you're gonna have to make some changes to the ventilator. So using your ABG. So on ABG, these components are very important. You don't really have to pay attention to the bicarb, but I've included it here for completeness. So pH, PCO2, PaO2, and using your oxygenation or pulse oximeter. So pH and PCO2, the first two components, can help with acid-base determination. Excuse me. If there's a respiratory acidosis, you can increase your ventilation parameters. Likewise, if there's a respiratory alkalosis, you can decrease your ventilation parameters. And with regard to your PaO2 and your oxygenation, if you want to change any oxygenation, you increase the FiO2 or add or change the PEEP to help with this. So I've included an example just to keep this kind of active so we can all stay active this morning, or I guess this afternoon for you guys. So this is a real case that happened on Sunday. We had a 7-year-old female with polytrauma presented to the ICU after a motor vehicle collision at high speed. The patient underwent an XLAP for intraperitoneal free air and presented to the ICU afterward. And then patient needed mechanical ventilation. This is a chest X-ray. You can see endotracheal tube sitting a little bit high here. So again, our patient, 7-year-old intraperitoneal free air, underwent XLAP. After the procedure, patient was intubated, brought to the ICU intubated. Patient was in need of mechanical ventilation, remained paralyzed following the surgery. The patient weight is 30 kilograms. So I'm just asking the audience, anybody can answer. What ventilation mode would you choose for this patient?
Lian, Archana, and Saibal, please answer. You're going for your exams in another 15 days.
Whatever you have understood, you please speak. May be okay, may not be, but participate in the discussion.
So you want to use a volume control? Oh, sorry, go ahead.
SIMV.
So SIMV, correct. The only thing I'll say is if you're using SIMV, then the patient, any intermittent ventilation that the patient will be triggering won't really happen, right? Because the patient is still paralyzed. So SIMV is part of volume control or pressure control. So you can say volume control with SIMV in case you want to support those breaths, but you are not wrong. So volume control or pressure control here, or volume control autoflow. What tidal volume should we set?
Lian, Archana, Saibal only. Meghna, if you can.
So remember your 6 to 8 cc's per kilo.
Around about 50.
So 6 to 8 cc's per kilo. So 30 kilos, so I'd set around 200. Peak inspiratory pressure, probably around 20 to 30 for this patient. 30 is probably a little bit on the higher end. But the peak inspiratory pressure, if you're choosing peak pressure control, I would set it around 20, see what tidal volumes we achieve, and we can titrate that way. Again, this is for a 7-year-old, so compliance is a little better. And the risk of barotrauma isn't as high as a neonate. So around 20 is okay to start with, and then titrating up. The PEEP
PEEP will be 5.
Yep. Always administer PEEP 5. P max.
What is the max? What is the max? What is the PEEP max you can go up to?
You can actually titrate all the way up to PEEP of 30 if you're doing some recruitment maneuvers. A lot of patients or a lot of physicians in the ICU will set a PEEP of 30 and inspiratory hold in order to open up alveoli. But this, for if you're maintaining volume control or pressure control, generally the highest I go in the operating room is about 10. The reason being is PEEP doesn't come without consequence. If you think about maintaining continuous pressure in the thorax, you expand the lung, you're maintaining that pressure. When you expand the lung with PEEP, you decrease any venous return to the heart. So if you increase your intrathoracic pressure and decrease venous return to the heart, your blood pressure will drop. So you can get hypotension with too high of PEEP. So this is a value that I wouldn't increase all of a sudden because it can lead to that, but you can slowly titrate it up.
Isn't this antagonistic to the rate? Because if you are increasing PEEP, then the respiration should not be slowing down.
Correct. Yep.
Entire cycle of breathing will be slowed down because high PEEP is going to slow down the inspiration as well.
Yep, 100%. So the only time they use very high PEEP is for inspiratory hold or providing a recruitment maneuver to open up alveoli again. I think I talk about this later, but basically what you do is you increase the PEEP all the way to 30, you decrease the tidal volume and decrease the respiratory time. The way we do this in the operating room is on the APL valve that we have, we close this to about 30 to 40. So that's our PEEP. And we hold the ambu bag until we achieve a tidal volume and just hold there for about 30 seconds. What that does is you're essentially turning the PEEP up to 30, but just manually holding that volume and not providing any respirations at all. Now what that does is just slowly expands all the alveoli and opens up the lung again. But again, the things that you would see hemodynamically are decreased venous return, resulting in decreased cardiac output and hypotension. But immediately when you release that PEEP and you go back to your regular ventilation, you'll see venous return come back to the heart and the and blood pressure improve afterward.
Okay.
P max, I would set around 30 to 35, just an alarm to avoid any barotrauma. And the FiO2 you could set probably on 40% and titrate to effect. So same example, that same patient has the following ABG 1 hour later. So pH is 7.16, PCO2 65, PO2 is 200 on an FiO2 of 40%, bicarbs 25, oxygenation 99%, SpO2. So what's the issue here?
CO2 retention.
Yep. So this is a respiratory acidosis, retaining CO2, leading to a decrease in pH. So what changes can you make here?
Expiratory time has to be increased. I ratio to be.
So yeah, you can increase your expiratory time. If you are treating this patient like a COPD patient, that would be 100% correct. I didn't go that detailed, but I just said to increase the respiratory rate, increase the tidal volume. So this is CO2 retention. However, that's for COPD patient, someone who is not able to collapse their airway all the way and expire for expiration. But with hypoventilation, more of an acute process. If the patient was just intubated, this is probably due to hypoventilation. So in order to achieve better values here, you can increase your respiratory rate, increase tidal volume. So another ABG later on, pH, this is the next day. pH 7.42, PCO2 38, PO2 is 59 on an FiO2 of 21%, bicarbs 25. So what's the issue here?
I would increase the FiO2.
Yep, so this is hypoxemia. So you can increase FiO2 and increase PEEP if you need to achieve better oxygenation. So problems with mechanical
in the previous case, won't you increase the flow rate? Or was he getting the flow rate which were optimal?
He was getting, this was getting the flow rate. It's just, you can increase the FiO2 here, increasing the respiratory. Right.
We agree to that. I say, will there be any need to change the flow rate as well?
The flow rate as in the respiratory rate?
The inspiratory air flow rate. Or that will automatically get increased with FiO2.
I think we cannot control that singly. By these parameters, the flow rate changes.
No, we can change the flow rates from 5 to 8.
So the flow rate shouldn't make a difference though. If you have if you change to 100% FiO2, as long as you have fresh gas flow at certain rate, I think the machine will automatically
increase the flow rate.
Provide. Right, because if you change this FiO2 from 21%, that's an admixture of room air. I mean, this is just room air. If you change it to 30%, that'll be an admixture of room air and oxygen. And then if you go to 100%, it'll solely take from the oxygen source and provide that flow so that you achieve this FiO2 of 100%. Now, if the patient were actively crashing and the PO2 pulse oximetry is rapidly desaturating or dropping, and you need to switch to an ambu bag, you would have to manually increase the flow rate on your oxygen outlet in order to achieve 100% FiO2 as fast as possible in the ambu bag and provide ventilation that way. So if you were using an ambu bag, yes. Does that make sense?
Is Supriya there to address her queries? Or she's left?
She's there.
Okay, anyway, please carry on. We'll talk to her later.
Yeah, sorry, I'll try to speed up a little. I know it's already getting a little late. So
we are not in hurry.
Okay. So problems with mechanical ventilation. So you can have two different issues, volutrauma and barotrauma. So volutrauma is lung injury due to a large distending volume associated with a tidal volume of greater than 8 cc's per kilo. This is why we set our tidal volume to be between 6 and 8 cc's per kilo. Barotrauma is lung injury due to high airway pressure, and this is what we were talking about with the neonate. This is associated with a mean airway pressure of greater than 35 millimeters of mercury. And infants and children are more susceptible, especially small infants and children are more susceptible to barotrauma, which is why we were talking about before, using a pressure control setting, and so you can limit the pressure that you're administering to an infant. Both of these can lead to acute lung injury, not just at the anatomic level, but the cellular level also. And this is a real picture from a baby that we had about 2 years ago, who had some pulmonary pathology, didn't even receive high airway pressures. The mean airway pressure actually didn't even exceed 35 millimeters of mercury and resulted in a tension pneumothorax that necessitated rapid decompression with a chest tube. So we talked about pediatric ventilation. I wanted to touch on neonatal ventilation, just some differences that we see. And the take-home point for neonatal ventilation is just vigilance. You just have to be very vigilant about ventilating these kids. The reserve is much lower than any other patient, so if they're about to desaturate, they will drop very quickly within a matter of seconds. So just to be highly cautious in titrating any ventilation for them, and to be extremely vigilant just about taking care of these patients and being on the lookout for any pulmonary pathology that may necessitate ventilation. So a lot of the principles are actually very similar. So neonatal physiology, as you remember, the chest wall is much more pliable. Their chest wall will collapse with end expiration, lead to alveolar collapse. It's really hard to maintain their functional residual capacity because of this. And they use 2 to 3 times as much oxygen as adults. So their O2 metabolism is much faster, which also leads to rapid desaturation. So problems with oxygen. Oxygen always good, right? For the residents? No, it's not. So hyperoxia can lead to several different pathologies. So problems with oxygen that you can have are retinopathy of prematurity, oxidative lung injury, respiratory depression, can suppress erythropoiesis. Physiologically, it can lead to pulmonary vasodilation, which in cardiac kids can lead to pulmonary congestion, and systemic vasoconstriction. Bottom line, use the minimal FiO2 to achieve ventilation goals. And now you may need to titrate down slowly. So it's not terrible to use 100% FiO2 in these children, but make sure it's just for minimal amounts of time. The neonatal ventilation goals, the same as any patient. Volutrauma, barotrauma, and hyperoxia can all lead to bronchopulmonary dysplasia, which is basically a chronic lung disease that affects the airway from the bronchi all the way down to the alveoli. This can lead to chronic lung disease, lung scarring, and can go on into adulthood. You want to minimize the peak and mean airway pressures and provide adequate oxygenation. Your goal for these patients is an oxygenation of 88 to 94% and to maintain normal carbia, PaO2 or PaCO2 of 45 to 60 millimeters of mercury. Your ventilator settings, same lung protective ventilation. So your tidal volume, 6 to 7 milliliters per kilogram here. Use PEEP to prevent atelectasis, and you can utilize recruitment maneuvers to reverse the atelectasis. So this is what we were talking about before, which is an inspiratory hold at a certain pressure. And what this does is it pops open alveoli. Because these infants are so prone to atelectasis, what you may need to do if the patient is constantly saturating around 85 is provide a recruitment maneuver. You don't want to still exceed about 30 millimeters of mercury, especially in a neonate, because that can lead to barotrauma. And these may not be well tolerated for prolonged periods of time. So I would do these at maybe 10 seconds at a time and release, 10 seconds at a time and release. And I know you guys have high frequency oscillatory ventilation available. I just wanted to touch on this. I am by no means an expert on high frequency oscillatory ventilation, something we never use in the operating room. We don't usually titrate these or change any ventilator settings. Usually the respiratory therapist or whoever is managing the ventilator will titrate this ventilator setting, but I wanted to talk about this just briefly because you guys will see it, I believe, in your NICU. So high frequency oscillatory ventilation is used as a rescue when conventional ventilation has failed. I've included a table here with indications. The time that we see this is for any kid that is born with CDH and has very high persistent pulmonary hypertension. That's the main indication for us when we're involved with these children on high frequency oscillatory ventilation. I think both of the ventilators that you guys have should be able to do this, especially the baby log, I think can. The goal with high frequency oscillatory ventilation is to limit lung injury and provide better outcomes. It's basically high frequency ventilation with a low tidal volume. The tidal volume is equal to or less than the dead space ventilation. And sorry for the typo, you maintain a constant mean airway pressure to maintain the lung patency. High frequency oscillatory ventilation is titrated by adjusting the amplitude, frequency, and inspiratory time. So this is conventional ventilation. So remember the pressure increasing and decreasing to ventilate nice and slow, respiratory around 30. In high frequency oscillatory ventilation, it's all just that, it's oscillations. And the key here is you're maintaining a mean mean airway pressure here. Instead of an inspiratory pressure and PEEP, you're maintaining your mean airway pressure. So the patient was ventilated, they're better. So now what do you do? Try to wean to extubate. So weaning to extubate can be very complicated, differs patient to patient. So just some basic concepts that I think about in the operating room. And remember, operating room is very different than the ICU. And there's certain things that we take into account. Most of the time have healthier patients because they don't have a reason to be in the ICU. They're coming for a surgery or an anesthetic procedure. We've sedated them, they're baseline healthy, and we can extubate them. So for patients in the ICU, the main thing is you just want to ensure that the patient is not heavily sedated. Whatever pathology they had has improved. And any neuromuscular blockade that they have been, if they've received any rocuronium, that has been reversed. You want to ensure normothermia because hypothermia can lead to altered mental status that can affect being quote unquote awake enough to support their ventilatory drive. Extubation criteria, every institution has different extubation criteria. This is kind of something that I put together for something that we use in the operating room as a ventilator weaning to extubation criteria. So you can make sure pressure support is around 5 or less, PEEP is around 5, and your FiO2 is less than 50%, maintaining oxygenation. And what this does is it mimics what the patient will do once the breathing tube is out. Once you put the patient on manual ventilation, just check that the patient has an adequate respiratory rate for their age, a tidal volume of at least 5 to 6 milliliters per kilogram, and that their end tidal CO2 is less than 60 millimeters of mercury. Reason being here is that an elevated end tidal CO2 reflects an elevated PaCO2, and CO2 narcosis may lead to hypoventilation. You can check for a cuff leak, which is a leak around the endotracheal tube cuff. And the reason being for this is with prolonged ventilation, you can have laryngeal edema and subglottic stenosis. Premature extubation when you have laryngeal edema and subglottic stenosis can lead to airway collapse. And once the endotracheal tube is out, may necessitate urgent intubation or reintubation that may be more difficult than previous. And always be prepared to reintubate the patient if they fail. Ensure an ambu bag is nearby. Ensure that you have a mask for bag mask ventilation if they do fail. This was my dog that was working on the presentation. So that's all that I had. Let me just stop sharing screen.
That was a cool pick, last of all.
Thank you.
But before the weaning that you stated that these are the minimal setting, how long you have to observe the minimal setting? So to say that now it's the time to wean.
Sure. So I think in the ICU and operating room, it's very different. In the ICU, they'll monitor them for a good 2 hours just to see. They'll draw serial arterial blood gases, see if they're maintaining oxygenation, making sure that PaO2 is okay. In the operating room, we have maybe minutes to seconds. And they're generally healthier. So I would say in the ICU and neonatal ICU, you can definitely take your time, and especially because they'll have different pathologies, and probably will be a little bit more sick than the patients that we're taking care of in the operating room. So I would say our usual goal whenever we were rotating in the ICU is during morning rounds around 6, 7 a.m. We'd say, okay, this patient is ready to extubate maybe later on. Let's put them on pressure support and let's see if we can kind of trial how they're doing, put them on a spontaneous breathing trial for the morning, plan to extubate around noon. So we'd give them 3-4 hours just to see how they would do. And that gives you time to minimize sedation, to decrease sedation, really wake them up and see how they'll do.
And what precautions to be taken if that you find that he's still not, he has been extubated early. So when you re-intubate, will it be a more prolonged observation before deciding again?
I would say so. If they fail to extubate and they aren't ready, I would wait a long time in order to check some arterial blood gases, see what's going on, see what the baseline underlying reason for their failure of extubation was. If it was sedation, if it was a pulmonary pathology, if they need some recruitment maneuvers to maintain any atelectasis that may have been going on, or if anybody has any underlying reason that could be elucidated with their failure to extubation. Because a lot of times we'll think, okay, the patient's better, but we're on mechanical ventilation. We'll reverse everything, get ready to extubate, and then we'll realize, oh, this patient still has neuromuscular blockade on board that we need to reverse, or they have some undiagnosed pneumonia that's not allowing them to extubate, or they're just simply too weak from being in the ICU too long.
Vishwas, you just exceeded what I was expecting. You have just done a wonderful job.
Thank you so much. Thank you for this invitation again.
And this is just part 1. So there's going to be part 3 according to your availability, because we are definitely going to have our own share of problems. This was more or less now theoretical for us. We'll start things and we'll come up with our problems. So I have in mind is that we'll have scenarios from my end, which I'll pass on to you. So that time we need to work together that what we went wrong or where we went wrong. I would
definitely
ask my students, everyone, final years and everyone to ask questions one-on-one. And Vishwas, if not a problem, then we would be uploading it on our medical college website and also on our YouTube channel.
Definitely. Okay. And a lot of this presentation, I just have to say, came from the Society of Pediatric Anesthesia. They have some great resources on their website, and you just have to fill out a survey, and they have a lot of lectures that pertain to pediatric anesthesia. They're readily available to the public. And I think the website is www.pedsanesthesia.org. So a lot of the lecture material that I got today, I actually used their lectures to have kind of a framework for basic ventilator strategy, ventilation, how to ventilate neonates pediatrics. So it was very helpful.
Right. So all the Meghna, Nitesh, Narendra, any questions, please ask. It can be very dumb and a basic question as well, but you should ask. As I said, Vishwas, you would not believe it that because we have in India, as you can imagine, that we have more number of patients than the number of beds, and we can't do surgery just because he can't go to any other hospital because the same problem in every hospital. So we are operating, and then we are ending up doing ambu ventilation for hours and hours.
Oh wow!
You wouldn't imagine that the mother and the father are engaged in doing ambu. So
oh my gosh,
that is a suboptimal care. But things would improve once we have our, I think you can call it the state of the art vents we are putting it.
Oh yeah, definitely.
Yeah. So please, my residents, please ask questions.
And I'll provide my email here in the chat. If you have any questions, feel free to email me. Oops.
That's
and
so
again,
good of you.
I am not an expert in any of this, but I'm happy to help.
Yeah. So definitely it was such a wonderful session. And I think you really taught so lucidly. I think it should be very clear with the residents. And as we go along, tread along these paths, we will find some problems. We'll definitely get back to you. If they were, I think Dr. Dipanjan, he asked some question, and after that, he must have got the reply to it.
Oh, okay, yes.
Then how you decide that tidal volume and PIP that you have already explained.
Yeah.
So Dipanjan, you have any query right now, then you can ask. You are still...
No, ma'am.
Is it clear now?
Yes, ma'am. I could understand after he gave the example. After that, I could understand.
So you could understand.
So,
Yes.
So as you see, Vishwas, people are not asking question means your lecture did very fine.
Great. I'm happy to hear that.
I think me and Sujay also badgered so many questions that partly their doubts were cleared because of our intervention. And
I'm glad. I mean,
did not trouble you so much.
no. I'm glad because I was going through this presentation. I didn't think it would be long or in-depth enough, but then I'm glad we kind of had and I think it's better to keep it more interactive and kind of like conversation style rather than just a lecture.
Definitely, it is quite a boost to the speaker also. So, Dr. Sujoy, can we, what do you plan? Can we call it off now?
Supriya is not there. Supriya was on leave and she was really, I appreciate she joined on a leave day also. And she was part and we could clarify a lot. But I would again open up Meghna and others if they want any queries to be sorted out. Please ask here only.
Sir, myself, Meghna. Sir, we often ventilate the patient and patient is on ambu ventilation. And sometimes I've seen if a junior resident is on pre-anesthetic checkup rounds during the evening hours, and she comes and she just visits the patient, and then she says, we think that we should sedate the patient. Sometimes we sedate the patient, sometimes we don't sedate the patient with Midas while the patient is on ambu ventilation. So, sir, can you give us a guideline about it?
I think whenever a patient is intubated, any sedation should help. Sedation just helps respiratory mechanics and allows for a more adequate ventilation. If you have an endotracheal tube, it's actually one of the most stimulating procedures and one of the most stimulating things that can occur to a patient. So I think in general, any patient that's intubated should have some type of sedation on board. That being said, just remember that things like midazolam and other medications, fentanyl, they will take a while to wear off. So if you're thinking about weaning to extubation, just think about that and that they may lead to altered mental status, and they have to think about this later on. But it does lead to better tolerated ventilation.
Vishwas, we encounter a lot of tube blocks, and I think we lose a lot of babies because of we do not have the 1:1 ratio. So we have a single nursing staff and a doctor for maybe 4 or 5. So we lose many of these babies because I believe there may be a clot or a secretion and it was tube block.
Yep.
So do we have these vents with some alarms which can tell us that there's a tube block?
The alarms you would see are increases in your peak airway pressure. They don't have exactly an alarm to maintain or to tell you that it's because a tube is blocked, but you would see an increase in your peak inspiratory pressure, and you may notice that your tidal volumes aren't achieved adequately. So that's the way that we tell in the operating room. The things you can do is if it's a small baby, 8 French suction catheter, making sure you have suction catheters. And what you can do if it's a small baby, stick that 8 French suction catheter down to suction out any secretions. If that doesn't work, you can actually administer about a cc or 2 of normal saline down the airway and then suction down the endotracheal tube to take any secretions out.
But how frequently do you do that, or you do that only on SOS basis?
In the operating room, we just do it on as needed basis, but at bedside, sometimes these ventilators and the circuits that you have will have inline suction that you can suction through.
Okay. Nitesh, Saibal, Meghna. Meghna has already asked.
Sir, can you tell us something about CPAP?
So CPAP is basically just continuous PEEP. What CPAP is if you place a patient on the ventilator and you set a certain continuous positive airway pressure, you're basically maintaining PEEP to the airway and the patient's breathing on their own. So spontaneous ventilation with added PEEP. So if you think about OSA patients, they say, okay, I go to sleep with CPAP. They put a mask on their face. They have continuous positive airway pressure to maintain alveoli open. Same thing with the breathing tube. If you have a breathing tube and you maintain CPAP, you're maintaining positive airway pressure in the lungs, but breathing spontaneously over that. So what you're doing is maintaining small airway patency and alveoli patency and allowing that not to collapse.
CPAP consists of one of the weaning intermediates before the wean. I think in our institution also, they put all patients and observe on CPAP for some time before they fully extubate. Is that correct?
Correct.
Are there any more questions? Since the email address has already been provided by Dr. Vishwas, any other queries can be directly conveyed to him. And I think the resident should make it a point that while we have the international faculty or other faculties of his team, they should share with their co-residents even across the borders, because it is a training beyond boundaries. So they should tell about the other people, residents in other organizations also, to be part of this program so that they can benefit. Maybe that they are not provided with such facilities which are provided at MEMC. So they can anyway link into this program, and so that we benefit the society at large. So that is the main aim, that you ultimately land up being good pediatric surgeons, good doctors.
Ma'am, I had requested Dr. Vishwas for also another lecture on a very common thing which we are encountering, and that is sedation policies.
Definitely. I think after once these ventilators are installed or in the process of getting installed while the people are getting trained, we'll have another lecture from you
that is not
for the practical problems that we are facing, and maybe with few case scenarios.
No, I'm saying this is not ventilation related, another lecture. I have already.
It's for the non-operating room anesthesia, correct? For outside locations and monitoring?
For sedation, for
sedation, yep.
procedures, we do sedation. So I have requested him to talk about what are the accepted sedations and what are the monitorings we can do. Because every child, we cannot go for a GA. So that is very practical, another thing which he would probably give a date and a time when we'll talk about that. Sedation policies we should have in place.
We'll have more interactions with you in future.
Definitely.
Thank you so much for joining and enlightening our audience. And it was really wonderful. And obviously your aura is such that the residents got so comfortable with you. That is very important. Very
Thank you.
With the faculty.
Appreciate it.
Okay.
Thank you.
I think, Sujay, I think you formally call it off.
Okay. Bye, Vishwas. I'm ending the program.
Okay. Bye. Thank you.